Good evening, everyone. We're going to get started. We'll give it about a minute for people to filter in here. If you can bear with us, we will be starting in about a minute. Thank you.
John?
Yes.
Yeah, so some of the people that are signing in are gonna be, looks like Lawrence Chang too. I just sent them the link because they wanted to come onto the lecture as well.
Okay.
So you're gonna see two Lawrence Changs or more
Okay.
from, they're coming from some of the residency programs who are actually interested in seeing a lecture. So
Yeah.
if you see there's two ones right there, so
Okay.
just letting you
No,
know.
no, that's fine. Thank you. Thank you.
Welcome.
Welcome,
I just sent them
everyone.
the link.
We welcome everyone.
Welcome,
Okay,
everyone.
we'll start. I wanted to thank everyone this evening for joining us. I apologize for the little nasal voice I have. Have a bit of a head cold today, but so we'll be recording this lecture and sending it out to everyone who has registered. Probably next week. You'll get an email with the link, and you can review this again. So today's virtual community lecture will be given by Dr. Lawrence Chang. Dr. Chang is a non-operative fellowship-trained sports medicine physician who specializes in sports and musculoskeletal injuries, arthritis, and tendon injuries, diagnostic and interventional musculoskeletal image-guided procedures, and regenerative medicine. He sees all athletes and patients with any musculoskeletal condition to help optimize their function and quality of life. He completed his internship at Coney Island Hospital with residency training in physical medicine and rehab at Burke Rehabilitation Center or Burke Rehabilitation Hospital, and immediately followed with a fellowship in sports medicine from Montefiore Medical Center in the Bronx. Dr. Chang has served as assistant team physician for a wide range of high school, collegiate, and professional sports teams. He currently acts as one of the team captains for the New York Roadrunners and triathlon events, ringside doctor for USA Boxing, Global Association of Mixed Martial Arts, and World Kickboxing Association. He is an active member for the Special Olympics, Healthy Athlete Promotion events. Dr. Chang is a published physician and holds membership with professional societies, including the American Medical Society for Sports Medicine and the New York Society for Physical Medicine and Rehab. He continues to have interest in research in biomechanics, innovative technologies and treatment, sports medicine, Special Olympics, combat sports, adaptive sports, musculoskeletal injuries, regenerative medicine, osteopathy, complementary and alternative medicines, public health, wellness, physiatry-related injuries, and treatment. Dr. Chang sees patients in our Manhattan office at 645 Madison Avenue. This evening, Dr. Chang will be discussing the management of traumatic rib fractures. If you have any questions throughout the lecture, if you could please type them in the question and answer section at the bottom of your screen, Dr. Chang will answer them at the end of the presentation. And with that, I turn it over to Dr. Chang.
Thank you, John. So that was a great introduction. I know I do a lot of things and everything, but I try my best to be as holistic as I can. I'm an osteopath, so I try to look at the whole picture. Also non-operative sports medicine, so primary care sports. I work for Rothman Orthopedics. The reason why I'm doing traumatic rib fractures, the management, is because it's something that I am very interested in uh, managing myself for a lot of the patients that I see, especially in sports or those with acute fractures of the ribs. I've seen a lot of these cases when I was an intern and also in surgical rotations, and I still have an interest right now in orthopedics. Um, so yes, management of traumatic rib fractures. So if you look in this picture right here, this is Manny Pacquiao versus Luke Matisse. I may not have pronounced it correctly, his last name, but this was when Luke actually got a rib fracture from Manny Pacquiao. It was a great fight, but this is one of those ways you get traumatic rib injury or fracture itself. So let me get into the nitty gritty of what's going on. Actually, before we do that, let's just talk about disclosure quickly. I do not have any financial disclosures or conflicts of interest with the presented material in this presentation. The lecture topics intended for educational purposes, not to be intended as encompassing review on traumatic rib fractures. This is more about the management of traumatic rib fractures. This is also to inform the public understanding about traumatic rib fractures, especially the options that are available for such, and how to manage it in the best way possible to improve one's quality of life. Um, Rib fractures are actually pretty common, but in this lecture, of course, I'm going to tell them more traumatic. So actually, some sort of injury to the rib itself. Um, you know, it's actually rib fracture just basically means a broken rib. It can be very difficult to treat depending on the severity and complexity. I won't go into all the details, but I'll try to get, just general idea of what we're talking about, the severity and the complexity. So there are different forms of rib fractures. There are simple and complex. So simple means a simple rib fracture, one part of the rib is broken. Complex can mean multiple ribs are broken, or there are different shapes and sizes. There's a high and low parts of the ribs that are actually being fractured. The higher parts is the higher part of the rib, usually the first or second, maybe third part of the rib, which is injured. And then there's a lower part of the rib, which is the lower ribs itself. Could be 6, 7, 8, 9, 10, or 11, 12 ribs that are injured. Those actually tell you whether or not there may be a organ injury or there may be something else that needs to be addressed besides the rib injury. Someone may have to go to ICU or the inpatient hospital to do more management for the uh, extra rib injuries. Usually upper rib injuries are pretty rare. They deal with more vascular issues but it's actually mortality is higher. So that's something to consider if you ever have a higher rib fracture. Now there's one or multiple. So one means one rib fracture and multiple means many. There's closed and open rib fracture. So if it's closed, might be better than open, depends on the situation. But if it's open, then you might need some surgery or some sort of closure in that area. There's also non-displaced and displaced rib fracture itself, so that's important to note in the severity and complexity itself. Meaning non-displaced, meaning it's not two ribs are not being moved apart or separated. Displaced means they're actually moved apart. Just the idea. There's other issues that we deal with the severity and complexity of rib fractures, comorbidities, other medical conditions you have, medical surgery histories, and even a mechanism of injury, that also matters too. If you have a high velocity injury or like a punch in a rib in a certain way, that will tell you what kind of rib injury they have and how you're going to either do surgery or how you're going to manage the rib fracture itself. Just the simple idea of looking at simple versus complex rib fractures. Simple can involve just like one part of the rib actually injured on the left side, and the complex ones just to, if you look at it, oh my God, multiple things going. You get pneumothorax, meaning your lungs have a hole in your lung, and then there's air. Lung contusions, meaning you bruised your lung. Emphysema, uh, any kind of lung injury or it could be heart, and then even can go down the levels itself. This is for your information to look at. If you want to ask more about this, we can talk about this later. But for the purpose of this lecture, we're going to do more of the traumatic rib fracture management. Just a little bit more information. Like I said before, the higher rib fracture, we're about blood vessels, vascular, brachial plexus. Lower ones are liver, spleen, middle areas, lung, and heart. So just quickly on the pathology of traumatic rib fractures, any chest injury anywhere on the ribs, front, back, side, sternum, then you get a bone fracture, broken. Then the bone is deformed. Then you have maybe breathing problems, shortness of breath, chest pains. So that's just the gist of the idea of how it happens. Now, the most common traumatic rib fracture, what it causes, usually falls in the elderly, which has been increasing throughout the years. Um, Second one is adult motor vehicle crashes. And the last one is basically athletic and sports injuries. The younger people, the more and more they play sports, especially contact or collision sports, soccer, football, uh, boxing, you're going to have there's a high risk for those rib fractures. Others are like domestic violence. You think about children, some child abuse, if we had injury in the back of the ribs, you think about a fracture to itself. CPR, which is cardiopulmonary resuscitation, which is when you're pushing on the chest for anyone with a heart attack, you may fracture a sternum, which is the middle part of your chest, which is another form of getting the traumatic rib fracture. But that's also um, one other common way of getting the rib fracture, and then even sports in general, like we said previously. And the next one, I'm just going to go over also some epidemiology. This is just for your information. So the most important parts for this slide is the first three parts of your ribs are mainly dealt with some sort of high energy trauma. Maybe something hit you here, or maybe a football injury, maybe a car hit you here at the clavicle, or some guy uh, hit you here, something of this nature on the first three ribs, uh, those get fractured with some sort of hiney trauma at the top part. The fourth to 10th ribs are the most commonly fractured. So the mid parts to probably almost the lower parts of the ribs are pretty common. Um, I would say also the most important is like um, 40% of most trauma patients will have rib fractures. It's been increasing, like what I said, with elderly falls, and mortality is about 10%. Uh, and then if you look at the first two parts, a lot of people do seek rib fracture treatment and minute for rib fracture itself. This is an important slide I wanted to highlight. Rib fracture, pain, and opiates, epidemiology itself. There was a really good poster that was done by Dr. Avanti Badrinathan. The poster actually talked about about opiate use among people with rib fractures. So they did a large study with using the National TriNet X database from 2015 to 2022. About 60% of those patients had at least one fracture, one rib fracture, and they were at least treated with opiates, right? So that's pretty high. So most people just come to the emergency room, or just in general, anyone gets a rib fracture, maybe they go to their regular doctor, they get an opiate to manage their pain. It does make sense if it's a lot of very painful, but what's interesting to note, which is we actually have data now on this, is those with rib fractures were twice as likely to use opiates acutely, and those with rib fractures also were 50% more likely to use opiates than those with non-rib fracture patients. So those were some other injury to the chest or other part of the body, they weren't going to use, they're not going to use they're not going to use opiates as much as those with rib fractures. Um, Interesting note, after about a year, 6% continue using opiates, which is pretty significant. And about within that year itself, you have opiate use disorder. Usually it's among younger people use opiates. And the ones with using acute opiate use are those without any substance abuse history. So if you had some sort of substance abuse history, it's pretty significant. It does say females too as well, who use opiates on a chronic basis with if you have a rib fracture. So this is interesting data to know when we're treating our patients. Complications of rib fractures, most in part heart and lung issues, any injuries there. You have a cardiac arrest, which is heart attack, any emboli, which is can lead to having a stroke. Uh, it can also increase your hospital stay and use of ventilators or just oxygen itself. And then even for rib fractures, like what I said in the previous slide, it increases your risk for pain and then opiate use. In general, the overall management, I just wanted to go over this before we go over the more specifics of the management of traumatic rib fractures is usually pain control. So pain needs to be controlled from day one and ongoing. Usually you might need serial imaging. CT is usually confirmative. X-ray may not always see a fracture unless it's pretty overt. Ultrasound is an adjunct to the X-ray itself. MRI is can be used as well in lieu of CT scans. Um, a lot of the patients who actually have pretty severe rib fractures do go on to have an inpatient stay, may do ICU, intensive care unit. They have to be monitored for other complications, other medical issues that need to be taken care of, like bleeds or organ damage. Possible surgery if it's pretty severe. Most of the time, most of these patients are they go to outpatient and discharge for pain management and rehab. But that's not always the case. When I see a lot of my patients, they do not go to pain management rehab. This is actually pretty new. A lot of patients don't know about this, or the hospitals may not know how to manage this. So sometimes they would just go to maybe their primary doctor, but that primary doctor still needs to send them for some sort of pain management and rehab. Now, for most rib fractures, 6 to 8 weeks to heal for any rib, even for any fracture itself. But you would at least have them not be playing sports or going to work for at least a month, maybe a little more, depending on how they're doing when you manage your patient on the outpatient basis. And, like I said, rehab and physical therapy for recovery. We'll talk a little bit more about that a little bit more in upcoming slides. Okay, so I'm going to talk about surgical management. So this is actually one of the biggest things in rib fractures. If it's pretty bad, you go for surgery. Uh, Most are actually minimally invasive these days. Surgery is actually a lot of new techniques come out, which is pretty cool. Hundreds of techniques, a lot. One of the most common ones that they use for rib fractures, rib fixation surgery usually for severe pain, chest wall deformities, or flail chest. Flail chest, essentially when you have three of the ribs, they're whenever you breathe in, it doesn't normally, the ribs don't go up, they actually go backwards, and those ribs actually affect the way you're breathing. And there's more than two fracture sites itself. And that's pretty dangerous too. So that needs to be probably definitely surgically managed. High complex rib fractures actually pretty difficult even for surgery itself. You still need a lot of pain management with this as well. But different surgeons will have their own different type of techniques to managing this. Like what I said, all kinds of techniques. Now, surgery can reduce the morbidity and mortality in multiple fractures and flail chest, which are pretty big, one of the two big indicators for surgeries. This is just a table that I had from one of the articles. This is just indications for the surgery itself. Most important also is if there's some sort of non-union, the rib fracture is not going to heal, or you're concerned that it won't heal because pain's not getting better, breathing's not getting better, oxygen is worse and worse, then you may well consider that, of course, and then the deformity itself. And also on the way up, alternative reason for thoracotomy. So, opening that rib and actually fixing itself. Flail chest, like I said, so this is actually one of the major indications for surgery itself. If that rib is coming in and out when you're breathing, then that thing needs to be put in place, the hard bones. So We don't want any lung issues, more bleeding. Um, Oxygenation is a huge issue in this situation, and you pain too. High complex rib fracture is another surgical indication, of course. Uh, Criteria is three or less rib fractures in the second and fourth ribs. Each fracture that's equal to less than three fractures. The length of the middle fracture itself is less than or equal to 5 centimeters, and there's some sort of costal cartilage fracture. So within almost near that sternal area, that rib where you have a fracture. So that's pretty complex rib fracture. So again, some sort of internal fixation of the rib itself, reduce the fracture itself, put plates on, and then different ways of doing it. I'll show you the next slides. 3D printed ones are actually uh, one of the up and coming things that are coming up. I don't know how many of the surgeons are using this, but that probably should be more under a surgeon who could tell you more about that since I'm non-operative. I just including this in my lecture so you can know what options you have if there's rib fracture. But this is becoming more of a thing now. Ideas that are coming out for 3D printed ribs to help stabilize the rib fracture. So this is the most common like rib fractures. And in the 1900s, you had this really steel plate on the left hand side, multiple holes you see. You got to like stabilize that rib. Then you have 1972 Paris struts. Looks like you can kind of say it's like a holy cross. And then 1978, they had other ones. These are more the plates. And then the middle ones, there's claw plates. They all look like claws, right? And you just like put on a rib and you put it, you hold it in place like that. Now, the other ones that they do now is like Kirschner wire fixation, on any wires to kind of like seal it in place too. So you have a lot of options of how to do things, but that's up to the surgeon how they see the rib fracture and then what is necessary to do to um, stabilize the rib and then improve the patient's quality of life. 3D printed internal fixation. So nowadays we have 3D printed technology. It's awesome. You can actually print this out and then actually put it in the rib. I just don't know how much the outcomes are with this. There's a lot of research coming out with this. This is all new, but I think this is one of the interesting things that are coming out to help manage the rib fractures. Hopefully, um, it really helps out a lot because with 3D printed technology, you can actually measure it better for different ribs. Different people have different rib structures, rib types, so it's kind of cool, I think. Okay, so now onto pain management. This is a really big topic on rib fractures. This is something that's near and dear to me. Um, Oral and IV medications, topical medications, modalities, interventional procedures. So this is the major pain management stuff that we do to help with rib fractures. Um, Oral IV pain medications, usually Tylenol. You could use IV oral, NSAIDs, IV oral, gabapentin, Lyrica, SSRIs, SNRIs, any of the antidepressants may actually help as well. If you have also depression or some other substance abuse, may actually help too. Um, Opiates are actually the mainstay of a lot of the pain management. Ketamine, which dissociative and anesthesia, or, that may actually help with pain control itself, but one of the studies did note that it's probably better more for an adjunct to opiates itself and to reduce the use of opiates, since we use opiates a lot for rib fractures. Um, Usually, in general, you want to use multimodal pain management, which also includes injections and rehabilitation, besides oral and IV medications. Just wanted to go over a little bit more opiates. So opiates, like what I said, is a mainstay of treatments, acute and chronic. It's very difficult to wean off because the education on use opiates and limitations are, whatever is set there is nobody knows how to manage a rib fracture that well because this is something we just give. Sometimes it's just a knee-jerk reaction. Like I said, multimodal pain management is important. It's dangerous because you could have misuse, dependency, and addiction. So We are also still in an opiate epidemic in the US. Lots of side effects, cognitive, behavioral, constipation, gastrointestinal disturbances, even can be a barrier to rehab, rehabbing the patient themselves because patients may not want to exercise or do anything because it affects their respiratory function, but you just get used to opiates. So sometimes we have to find other ways to control pain and get out of that situation. So that's why we'll do other multimodal pain management to manage the pain itself, which includes probably injections if patient is amenable to that. Even topical pain medications too. You use lidocaine patches, gels, creams, Voltaren patches. Now, you don't want to use too much Voltaren patches. Sometimes it may cause more bruising. Some of the patients already have bruising on the ribs, so you don't want to cause more bleeding. So that's a consideration in that. Salon yes, you can use as menthols and salicylates, which are also in the class of NSAIDs. So you got to be careful salon pause too. You may also cause bleeding around that area. So make sure you're not causing more harm than good. And then any other topical analgesic just to control the pain as long as pain is controlled. This is the lidocaine patch that most commonly we give for patients to help also control the pain besides oral medications. Interventional pain injections. So this is a big topic of also my lecture and something that actually been helping a lot with reducing the pain itself. Usually used with refractory pain or even just the main, it's going to be part of the mainstay of treatment since pain is such a huge thing in rib fractures and also reduce opiate consumption itself. Epidurals and paravertebral blocks are actually the mainstay of the pain injections themselves to help reduce the pain. There was one 2019 retrospective cohort study that actually noted that there was 59% effective with epidural injections for rib fractures, but 30%, a lot of those patients actually needed more other kinds of interventional pain procedures. So sometimes rib fractures, it's not just a one-time injection that would help with the pain. You may need more than one and then multiple visits. Intercostal nerve blocks, which are between the ribs themselves, erector spinae blocks, which is you're injecting in around the back of your spine to help reduce pain around the ribs. I would say that's like a trigger point and also kind of epidural injection itself. Serratus plane blocks, so these are blocks in the ribs itself, which actually may are more localized, but it's actually a larger block, which actually may help to uh, uh, anesthetize those nerves, even open up the nose nerves that are damaged after they were impinged from the rib fracture itself. Um, Interesting to note that 2023, they had a meta-analysis that showed that peripheral injections had better acute rib fracture pain than conventional epidural and pain medications. So this is something to consider that we're still trying to work on to manage rib fractures. And in my practice, I like to do more peripheral injections plus pain medication. I don't find epidurals do as well unless I really use epidural to kind of reduce the pain more. It doesn't cover the area that I want to reduce the pain for rib fractures. There's a 27 study that was with rabbits for rib fractures. They use PRP, platelet-rich plasma, which is taking your blood and putting it back into the bone fracture itself, which helped to create a large callus formation and increase recovery plate thickness in rabbits. What does that mean? It helped them build bone around the ribs, but there are to date no human studies on platelet-rich plasma and rib fractures. So let me just go over some of the injections quickly. So this is a target sites for interventional pain management. So epidural goes mainly above that spinal cord. Erector spinae block is basically on that transverse process or the outside of that back of your spine, the bone. We inject that area, and then it's around the erector spinae muscle. It blocks that whole area, and then theoretically it seeps into the nerves there. Then you have thoracic paravertebral blocks. There's two types, but we can always talk about that later. That is another way of uh, anesthetizing the nerve that sends signals to the rib. intercostal nerve blocks, which actually more localized block for each rib, and serratus anterior plane block, which actually is multiple rib uh, multiple rib injection nerve block. These are target sites, extra ones. These are just nerves. This is for your information if you want to look at this. We'll talk more about this later if you're interested. Epidural injection, usually you can do under fluoroscopy or even under ultrasound um, for real-time injection of the medication above the spinal cord so you can anesthetize the nerves that goes to the rib. Paravertebral block, you do this actually mostly on ultrasound. It's basically between the transverse process and the rib itself, and you're basically putting medication around that nerve to reduce the pain itself. Um, and there's two types of techniques. That thing, if you want to discuss with that later, we can do that itself as well. There's intercostal nerve blocks. I'm just putting this out there, so if you guys want to talk about different injections to help with the nerve itself around the nerve around the ribs or help with the pain management, I can always elaborate that for you. This one is actually intercostal nerve blocks. You're actually doing more localized rib blocks. So let's say you had a rib fracture between ribs 5 and 6, and you want to anesthetize the nerves that innervate the rib around between 5 and 6. You're going to hit that area above that intercostal nerve bundle and anesthetize those nerves, and that will help reduce uh, the nerve pain around that rib itself. This is more localized for specific areas you want to target, and you may do more than one when you do this. Erector spinal block is actually one of my favorites. Um, there are different ways you can do this. Basically, you're putting it under the needle actually goes on top of the thoracic rib itself. I mean the transverse process. You put the medication in above that area, and then it hydrodissects that uh, fascial plane, and then it also hydrodissects the nerves itself, which actually helps to spread out the medication and anesthetize the ribs. This is just for your information. If you want to see what the erector spinae muscle is, this is how much coverage you can cover with the erector spinae block, and that medication seeps from the inside to the outside, and it's one of, I would say, one of the most promising blocks for even rib fractures. Um, this is how much it covers. It covers around, if you look on the left-hand side, covers about 10 levels, 5 up and 5 down. If I would go like T5, it goes 5 levels up, 5 levels down. It covers that entire region of the rib. So think about that whole thoracic rib being covered with the anesthetic will help a lot of pain. And this is one of the articles in emergency medicine. They actually showed uh, how much and how much the anesthetic actually blocked the region. So this is how much it blocks the front and the back region. And you could do it for bilateral, which is both sides. This is unilateral. There are some studies that say you can do one side actually block some of the other side, but if you were to do it, I would rather do both sides so you can cover both sides of the rib. So it is anterior block. So you're actually injecting more to the more of the axillary inside region of the ribs. Uh, and it's going to spread under the serratus anterior muscle. Either you do it on above that muscle or below that. Uh, and basically the needle kind of contacts that rib and hydrodissects the fascia, which anesthetizes all the nerves around the area where the rib is. So if you look on the right-hand side, this is how much the block covers. So it's a good idea of how much it can help. Rhomboid intercostal subserratus block. This is more of an other newer technique. I haven't used this as much, but this is another one that can actually help. It's a two-part block, so I'm just going to go over quickly what it is, but it covers mainly dermatomes or uh, the ribs that are around T3 to T12, okay? And you can use it for some of the abdominal pain as well. Uh, Rhomboid. So the rhomboid muscle is between the scapula. So between your shoulder blades, we put the injection there, and then it covers the upper part of your uh, ribs, around thoracic rib 5 and 6. And then the subserratus plain block actually covers everything under it, but depends on where you put it. So if you're covering T7, T8, you're gonna cover around those areas. So it's two-part block, but two different ways of doing things. Okay, and the other one's parasternal nerve block. If they have sternal pain, let's say you had someone who had like chest compressions and they had really bad pains on that chest, and they're still having pains literally around the area, you could do a parasternal nerve block, which actually may help with sternal or frontal part rib pains, more mid part. You can combine this with the other injections, especially the erector spinae block, where actually one of the studies did actually show that it actually had some pretty good relief in covering as much of the entire rib itself for rib pains. This is actually more of the nerves blocking each injection itself. We can discuss this more later if you're interested, but for the purposes lecture, I just want to show you more of what we can do. Pros and cons, this is for your information. A lot of these nerve blocks, I'm going to let you know, if you look on the right-hand side, with all these empty circles, there's not a lot of research on this because a lot of these blocks have only been here for less than 10 years, these injections, and these are all up and coming and new kind of injections to help with rib and back pain. Yeah, you can read these yourself, or if you want, you can always send me questions or if you have any comments about this, if you want to know more information, let me know. Rehab itself, which is another important part, pulmonary rehab, pulmonary toilet hygiene. So basically, you want them to be breathing, doing exercises to clear their lungs. Incentive spirometry, acapella, those are devices to use to help improve your lung power. Physical therapy itself, rib and thoracic mobilization. You want exercise to improve your vasculature, your cardiac, your heart to improve blood circulation, range of motion, assistive devices. You do want to do some band work and chest physiotherapy. Depends on the situation, but essentially we go low and slow with a lot of these patients for physical therapy. Breathing, pursed lip breathing is just one example, but like I said, learning how to breathe is important and learning how to be in tune with your lungs and your ribs and even your body itself will help with the pain and managing the ability to breathe on your own, uh, you know, properly is actually really important, especially in rehab. This is something that I think a lot of patients probably they don't go for after they have a rib fracture, in my experience. But this is equally as important as the pain management and even just following up with the surgeon and managing other things in your life, especially the quality of life, which I'll discuss a little bit in another slide. Acapella is basically, if you look at the lady, she's putting that device. You're basically just breathing in, basically breathing out. Those are just basically just trying to help with those lungs. Yeah, it's basically you're holding it, bringing it out, so you can build that power in your lungs. Incentive spirometer is another way. We look at different. It's more about breathing in to kind of improve um, that lung dynamic to make it bigger, okay? Improve that chest, okay? So these are two things that devices we can use to also help with the breathing. Alternative medicine and therapies. These are the things that I do include and even like talk to patients about. Acupuncture, which we do use well, now I'm actually certifying that I can use meridian points, which actually may help to reduce inflammation or even help you to manage the pain itself through other pathways to help with the rib, not feel as painful. Massage you can use. I would definitely probably just put that more into when your pain is better controlled. But I would say if you're doing massage, probably would be to your best benefit to go to someone who really knows what they're doing this. Gentle massage is better than hard, deep massage, but in general, I leave the massages more toward the end of things when pain is better controlled. I usually don't have this in the beginning when someone has a rib fracture. You can actually worsen the rib fracture. Um, Topical essential oils. These are other things you kind of think about. Let's say, for example, you have bruising or like you just have pain. These are things that you can kind of consider in topical pain management. Also, rib raising, craniosacral manipulation. I usually consider this like massage more in the end, manipulation. Craniosacral, you can actually do it probably in the beginning as well, just to calm the patients down because pain is may not just be in a rib. You may have other things going on. You may have shoulder pain. May have neck pains. You may have been in a motor vehicle accident. You may have had like a traumatic brain injury too. So sometimes a little bit more complicated than we think. So that's why we try to include other things to help manage the pain. Lymphatic drainage, sometimes people don't drain fluid well, so we include that as part of the massage. But I do that a little later on. I haven't seen anyone had that much in early on stages, but that's from my experience. But this is something to consider as also part of your therapies for the patient. Now, this is also, I believe, equally as important throughout your care for the patient, wellness. So sleep-wake cycle. If the patient is not sleeping or they're waking up at the wrong time because of pain or other things, you have to control that too. You have to help them find ways to do that. So maybe setting a timer, maybe setting visits to see somebody to do wellness, a therapist. Sometimes you may need a psychotherapist actually help a little bit, or just discussing with them on how we can sleep on certain positions and breathing and trying to help yourself to manage that pain and ability to sleep and wake up at certain times. Or maybe you take uh, separate naps throughout the day and then separate times you wake up. That way you can still control the pain, but also you have a quality of life. Hygiene is definitely important. Cleaning and everything is important. Nutrition, vitamin D, calcium, magnesium, collagen. The most important thing I always tell my patients is vitamin D, calcium, collagen. If they take milk, almond milk, something with protein, um, and even the vitamins, that actually helps a little bit too because it will help with some of the bone healing. Not going to be 100%, but even like maybe 1%, 2%, that's better than nothing. It helps a lot because everything you see the patient in a holistic view, right? Activities of daily living, you do want to actually talk about the patient about if they're able to do activities. Most of the time they're not in the beginning, but you do want to rehab them throughout the process. Happiness, purpose, goals, you do want to ask them about that. That's part of the rehab itself. Occupation, if they're working in a environment that's like manual labor and stuff, you definitely have to consider. Hopefully, you can rehab them, but some patients may not be able to rehab the whole time. Maybe have to do a longer course, or maybe they may not be able to work. So that's something you're gonna have to work with from time to time. But it's a discussion that you should have with your patients. Hobbies and environment. So sometimes, I find like which should be included. So the hobbies environment. So when you come home, the patients come home, they're only thinking about pain, 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 rib fracture, and all these other things. I have to manage these pains. All in my mind is on that. Sometimes talking about different hobbies and doing things may actually help. It doesn't have to be sports related, but it can be something that helps calm them down and keep them, um, you know, have some sort of quality of life. I think, um, you know, got to figure it out with the patient, family, significant other. That's important. Environment, of course, you do want to discuss with them about uh, possibly sometimes some patients stay at home all day and with the rib fracture and it's really painful, but it's important that they also still get out of the home environment so they can get some oxygen, even, it's also for your wellness too. You don't want to be having cabin fever all day. So you do want to have some sense of sanity, for lack of better words. Um, yeah, oh, this is like I just wanted to put this slide for you. Acupuncture, traumatic refract. These are points that we can use meridian wise to help with the refracture. These are more external points or more indirect points. You can use more localized points for the rib fracture, whether the rib fracture itself, or even most of the time we don't do that because it's painful, or you go to do acupuncture points on the spine itself to actually help out as well. Okay. Um, Takeaway points: most rib fractures can be managed conservatively. Surgery is dependent on severity of fracture and pain. Multimodal pain management is very, very important in all phases of rib injury. Injections can help to speed up and effectively control pain control and reduce opiate consumption. Rehab, rehabilitation of ribs is also very, very important. Breathing and bodily mobilization, thoracic spine, and the rib itself needs to be moved around, helps with the process of recovery. And lastly, wellness, I believe, is still equally as important because you need that. I wrote adjunct here, but I still think it's sometimes more than an adjunct because that you may have pre-existing issues going on. We need to manage that as well, in addition to the refraction, to get you where you want to go, uh, to improve your quality of life. And then okay, this is the last of my slides. Thank you, and remember, take some time to meditate and relax, and have John take the board.
Thank you, Dr. Chang. That was a great lecture on really comprehensive on the management of rib fractures. Excuse me. I do have a few questions for you.
Mm.
As you get older, are there certain ribs that are more prone to fracture if you fall or, whatever, do, regular activities as you're older?
So I would say, um, yes, there's. I wouldn't say so. I To answer your question, if there's certain ribs, I don't have. Number one, I don't have the data on that. But what I can tell you is if there's some risk factors, for example, if you had osteoporosis, osteopenia, like or some sort of thyroid or endocrine, like hormonal issues, or let's say your nutrition isn't that great, then yes, your ribs will have more prone to fracturing, in addition to it probably having injured in the past. But to answer your question of which ribs, if I were to give you a best guess scenario, I would say the upper ribs will be pretty bad because these other ribs should heal pretty well. But that's why we need to um, there's really isn't a date on it, but all I can say is that we need to be vigilant every time we see the patient with rib injuries. We do serial imaging, sometimes that would help to give us more of a picture of what's going on.
Great, thank you very much. Um, could you talk a little more about what bone grafting is?
Okay. So bone grafting, I mean, it's literally taking your bone, taking a graft, and you're just putting it in the area. So the things that I've talked about was mainly platelet plasma, which is taking your blood and putting it in that area. There are different types of putting, that's in the realm of kind of like regenerative medicine, even putting something back in that area just to keep it stable, right? Um, Bone grafting, essentially taking a bone and just putting it in that area in the hopes of it healing, and hopefully there's no rejection or any of that, and that actually gives you a better quality of life, better breathing, better mobilization of ribs. But in terms of the ribs itself, I don't know if if it's still being done a lot right now, or even that's a big thing. That's probably more in the realm of um, I guess the surgical world when it comes to that.
Okay, thank you. I think you answered this in one of your slides, but someone asked if PT was recommended after a rib fracture.
Yes, I would say if I go back to the slides, physical therapy is recommended after rib fracture after the pain is better controlled. So usually, um, there are two ways to go about this. One, if the patient can tolerate the pain during therapies, let's say it's not that bad and they could do therapies and they could actually do the breathing exercise, then yes, I go for it. But usually for me, a lot of the patients I have them do physical therapy after the pain is better controlled. and more tolerable, because sometimes some of the patients tell me that their pain is worse after therapies, and at night they can't sleep, and on that side with the rib is, even though they put a pillow and other things in there. And even with the pain stuff, because maybe they're working their ribs too hard or their muscles or their nerves, because it's still there's still impingement there. So but you still want to do physical therapy along the line. So physical therapy, I would say the most important part that I usually tell the patient, incentive spirometry, the second line right here, which will help to improve the lungs power.
Great, thank you. Um, Another question. This person had a slight fall,
Mm.
and the skin bruised, discoloration of the skin after this fall. The pain is just soreness to mild pain right now. Should she be concerned about this? What would you recommend?
Is it an
And
open?
also she's 75 years old.
Okay. Is it an open wound, or I'm sorry, I didn't get. Is
No,
it the you said the skin is
it's just bruised and discoloration of the skin.
okay. And then was it diagnosed as a rib fracture or
No, she hasn't done anything,
oh,
and she's just wondering if she should pursue this. Like I said, the pain is just soreness right now to a mild pain. Is this something she should be
oh.
concerned with? And if so, what should she be going to the emergency room or to see, someone like yourself? What would you recommend?
So my recommendation is, since you have pain and bruising, and if it's persistent there and it's still there for more than a week and it doesn't go away, or even the first few days, then definitely go to the emergency room to actually get it checked out. You may need an x-ray, they may need to do some blood work. It may not be a rib fracture itself, but then again, rib fractures are either traumatic or non-traumatic. So that needs to be worked up. And I I would say if 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 the bruising itself on a rib is considered to be a traumatic one, then I would recommend getting all the workup in the hospital, get that done. And then when that's done, um, you can come see me for a pain management or even for the rehab process itself. If it's a traumatic rib, if it's some other causes or other things, then like osteoporosis or um, other causes, then you may need to see other doctors, like an endocrine doctor, or you're actually might still need to see a surgeon, but I'm not entirely sure because it's a really broad differential in that case.
Okay, that's great. Thank you. Um, that is the last of our questions. I wanted to thank everyone tonight who were able to join us. For more information, or if you'd like to make an appointment with one of our physicians in the future, you can visit us online at rothmanny.com or call 888-636-7840. And just a reminder, we'll be sending out this recording to all registrants within the next few days. So please be on the lookout for an email. And wanted to thank you again very much. Thank you, Dr. Chang, and
Thank you.
everyone. Have a good evening.
Thank you. Have a good evening, everyone.
Bye bye.
Bye.